Is that it? Are we good? Okay.
Mhm. All right. Welcome. We will just give it a minute or two for people to join the room. All right. Well, good afternoon. Thank you everyone for joining us today. My name is Sonia Bell. I'm the Vice President of Administration for the Georgia Center for Oncology Research and Education. And with me today, I have Mr. Chris Anderson from Georgia Skin and Cancer Clinic. Chris Anderson is an adult nurse practitioner at Georgia Skin and Cancer Clinic. He graduated with a Master of Science degree in nursing adult practitioner from Armstrong Atlantic State University in 2003. Not trying to date you or anything. He also previously received a Bachelor of Science degree in nursing from Armstrong College in 1992. He has an extensive nursing experience in Savannah and currently resides in Savannah with his wife and 2 children. And apparently Chris enjoys spending time with his family as well as skiing, fly fishing, and playing golf. So thank you so much for joining us today, Chris.
Thank you for having me. I really enjoy doing these talks, although this is the first one I've done in this capacity. So I'm a little technologically impaired. So thanks for talking me through this, but hopefully this will go off pretty well. So I'm actually going to try to open my screen here to the PowerPoint presentation. And let's get that going. Okay. And it looks like that's up there, Sonia, right?
Yep, looks
We got
good.
it. Okay. Start the slideshow. We got it. Okay. So just to reiterate, I'm Chris Anderson. I'm a nurse practitioner. I've been in Savannah for a long time. I won't tell you the exact date, but it's gone by pretty quickly. I was a nurse at Memorial and then turned 30 and felt like I was getting old, went back to school, and I've been in dermatology as a nurse practitioner for almost 20 years now. And I've worked with Dr. Sydney Smith in Savannah and just thoroughly enjoyed it with that. So we'll move to the next slide. This is our clinic. We've got a number of satellite clinics in like Southeast Georgia and Southeast South Carolina, but this is kind of the mothership, and that's actually where I'm at today, and I'm seeing patients today, although I've got some time in between to do this talk, of course. We see, traditionally acne and psoriasis and eczema and fungal infections and all kind of stuff. But we, of course, see a lot of skin cancer and sun damage and do a lot of education. And we were just talking before the show that the weather in that picture is pretty much exactly what it looks like right now. That would be great if it was 70 degrees, but it's like 96 degrees right now and it's just cooking outside. So I guarantee there's people at the beach with and without sunscreen. Generally, if you're above 50, you've got some sunscreen on. If you're 20, you don't have any sunscreen on that right now. So, and those people are regretting it in about 6 or 7 hours with that. So what we'll do is kind of move forward and kind of go into some of that and do some education on, what the sun does, how it can help us, how it can hurt us. So some basic, background. So UV, so ultraviolet radiation. So we've all heard of that. So what is it? So the sun, that's like 93 million miles from Earth. And, there's a saying that that's the distance for light that's just right, so we can grow and photosynthesis and all that. But it's really, one form of energy that's coming from the sun. So that there's a lot of different sources that come from the sun, but that's what we'll focus on today. So there's 3 types of UV rays. And UVA, and you may see this on sunscreen. And so this ray goes a little bit deeper. And so that's the one that traditionally, in a nutshell, causes aging, causes wrinkles over time. And that depends person to person and your skin type and how much you've had over the course of time. Oftentimes it's used in tanning beds. That's the primary UV ray that you get there. That's also the ray that colors the skin. So the cells that produce pigment in your skin, that's what stimulates them. And in turn, kind of gives you a false sense of protection from the sun. So the myth that it kind of gives you this base tan and gives you this protection is something that we kind of grew up believing, but in fact, it can kind of cause more damage if you do that more and more. These rays also pass a little bit more effortlessly through the ozone layer. So the next is UVB, and that's the one that really kind of hits the top layer of the skin, and that's the one that actually causes more sunburns, even cataracts, and can stimulate the immune system a little more. And some of those rays are actually absorbed by the ozone layer. There is some studies that show that the more severe burns you have before the age of 20 sets you up for more skin cancer as you get older. And then this is just kind of your Jeopardy question. What's the other ray that comes? There's UVC. These rays would be pretty dangerous. Actually, probably life would not exist as we know it if these were not blocked by the ozone layer. So we don't see those on the back of sunscreen bottles. Fortunately, we don't need that protection. So true or false? Hopefully everybody knows this. True or false? You don't need sunscreen on a day like this. On a cloudy day at the beach, you don't need sunscreen. And of course, that is false. You can still burn. So UVA and then UVB would be the ray that would more likely give you the burn. Now, it may take you longer to burn, but you can still burn with that. And I have been guilty of this actually. At my daughter's graduation recently, I was guilty of that, just with other things on my mind. You're not thinking about that, and you can still get burned. So but that's a common myth with that. So so this kind of reiterates what I just said. So even on cloudy, cool, or overcast days, the rays can travel, and they can reflect off of snow, concrete, water. Clouds really don't give you that much protection. What are some other traps with that? So if you're skiers, or if you're at high altitudes, of course, that makes sense. You're closer to the sun. So skiers need to take extra care. Or the reflection off of the snow. The sun's light is strongest when it's the highest in the sky. So from between 10 a.m. and 4 p.m., you need to take more care. That makes sense as well. UV rays are stronger during the summer, or if you're closer to the equator, so if you're closer to, for instance, Mexico or the northern part of Australia, there's more intense sun in that area. So. All right, how about, so when you're listening to the weather forecast during the summer, everybody's heard of the UV index, and most of this is pretty self-explanatory, but this kind of gives you some numerical quantification, I guess, if you will, on what that is. So, so obviously if the UV index is a 10, which it very well may be, today in Savannah, for somebody that's got fair skin, if you don't have sunscreen on, you've got 10 minutes before you really start burning, according to this chart. And I would believe that today. Versus on a cloudy day, you may have a little bit longer. So if the UV index is a 1 or a 2, you may have 60 minutes, on that. So that kind of gives you an idea. I mean, the safe bet is to go ahead and, if you're going to the beach, if you're going to be working on the yard, go ahead and, put your sunscreen on, 15 to 30 minutes before you go outside, if you can do that. All right. So the next part of this is we'll go through the effects of UV exposure. So the first thing that we'll go through is a sunburn. And I'm sure we all know this particular gentleman right here. So that could be your husband, your friend. It could be absolutely you, in your youth on that. And that's the guy that wore the sunscreen. I mean, that did not wear the sunscreen, I'm sorry, but wore his sunglasses, or fell asleep in the chair, or thought he was invincible, and so we all know that feeling the next couple of days, when you're pretty red, and uncomfortable. So, and then we remember kind of UVB rays are the ones that kind of cause this. And then sunburn, just by definition, occurs when the amount of UV exposure is greater than the protection your skin's melanin can provide. So melanin's the color in your skin. So for instance, somebody that may be from Scotland, or prototypical, if you've got red hair, really fair skin, versus somebody that's got, darker skin, those people may burn a little bit more quickly with that. So the lighter your skin, the less melanin it has to absorb the UV and protect itself. However, that doesn't mean that everybody's invincible. So all skin, no matter the color, it can thicken and harden with continued sun exposure. And we can all get wrinkles later in life with that. So, so a good example is this next lady here. And we've probably all seen somebody like this. She's beautiful, but you can kind of see the wrinkles here and the thickening of the skin. And some of that's genetics. Some of that is sun exposure. Some of this may even be smoking that can impact that as well. So the thickening of the skin is called dermatoheliosis, but generally this is sun damage in relationship through the majority of her life. So this is another picture. You may see, guys with the back of their neck, for instance, farmers, notoriously, you kind of see this on the back of the neck, or golfers that have played golf for many, many years, that you'll see that on the back of their neck with that. So, and we all know this person at the beach, sun can be addicting. Some people really, really, really love it. They're addicted to tans, but as this picture shows, what one person's addicted to, the other person is not, so to each his own on that. So, all right. So the next effect of UV exposure. So number 2, eye damage. All right. So as you might imagine, I'll kind of break this down because this is a little bit wordy. So spending long hours, if you don't have any eye protection, not wearing sunglasses, you've got increased risks for developing cataracts. So those are the cloudy covering you see over the lenses of your eyes as you get older. Now that can happen no matter what, but sun damage through the National Eye Institute, they've shown that there's about a 1 in 5 chance that sunshine can actually be the cause of that. So sunglasses are pretty important with that. UV damage is probably the most important with that. So fortunately, cataract removal is pretty common these days, so it can be corrected. Now, when I first created this talk, they were really thinking macular degeneration was related to the sun damage, or one of the factors. They're finding that may not be the issue now. However, you want to wear, sunglasses when you're outside just to protect your eyes. Yeah, that's a picture of a cataract, of course, there. Believe it or not, you can actually get melanoma back behind the eyes as well. So that's another reason. All right, so number 3, so effects of UV exposure. How about skin cancer? All right, so over 5 million diagnosed skin cancers in 2022. So there's 3 main types that you may hear about. One is basal cell, the other is squamous cell, and the third is melanoma. And so we'll go through those quickly. We could do a whole talk specifically on those, but I'll give the synopsis. So melanoma is the one that's really the most aggressive potentially. So in the US, there's about 100,000 cases, or there's estimated to be 100,000 cases this year, over 7,500 deaths. As you get older, it becomes more common. However, you can get this at any age, and especially women, you tend to find this being a little bit more aggressive. Interestingly, we do a lot of teaching with melanoma. So this is a cancer of the cells that produce the pigment. So the melanocytes. And so you have these all over your body on your skin, of course, but you have these cells in different locations as well within your body. So for instance, even the spinal canal, the lungs, all over the place. So it's not always starting in the skin. Fortunately, that's not very often, but sometimes you can have these cancers in different locations within your body, and even in the retina, as I was discussing earlier, in the back of your eye. For guys, the most common place for melanoma is actually on your back. And for women, it's on the back of the leg. So you think, well, why isn't it on the face? But it's just one of those things that just happens. Bob Marley, that I actually tell my patients about, is he actually passed away from it on the bottom of his toe. So that's why we really recommend, having people get in a gown, so that we can see all of their body when we're looking for melanoma, because sun has something to do with it, but it may be just one of those things that somebody just gets it. So melanoma, as I move forward, I'm going to show you a couple of pictures. Now this is an easier one to diagnose because that's been there quite a while. And this is another one that's been there for quite a while. But typically these are moles that are darker. They have different color, and more often than not, despite these pictures, we'll find these as being flat. They're not typically these raised moles right off the bat. Everybody goes to the raised moles and say, they feel it and they say it must be a problem, but usually we're looking for something that's flat, different colors, irregular edges, or it's kind of the odd man out or the ugly duckling compared to the rest of the moles in that area. All right, basal cell. This is the most common skin cancer, and there's over 3 million of these each year, probably more than that. These grow really, really slowly. They don't metastasize, and they can really sneak up on you. And they come in most of the sun-exposed areas. So the face, the chest, the neck, the arms, and they don't metastasize, and by that I mean they don't spread to your brain or your lungs, but they will really get in there and tear up a lot of skin and bleed and all that. So typically we'll want to get those removed, and these are treated by removing these either through just an excision or a procedure of excision called Mohs that we do in the office here. In some cases, if they're really early, they can be treated by certain creams or superficial radiation or freezing with that. So I've got a picture here of one that's a little bit more advanced, where it's got kind of these red lines through it where the blood vessels are more noticeable, and there's raised edges right there. And typically that's a pretty common spot on the nose for these to come up, and they bleed a little bit more on that. So the color is kind of, when they're early on like that, it's kind of like this Pepto-Bismol pink, as my colleague states. All right, squamous cell, and that's kind of the third. That's the second most common skin cancer, and these also grow pretty slowly. However, these can spread, and over time those can metastasize. It typically takes a little bit longer for that to happen, but certainly you need to get those treated. I won't say aggressively, but those definitely need to be treated, and they're also treated through the same way that basal cells are treated when they're early on. So excision, or the Mohs procedure, as I said before, radiation, or sometimes the chemo creams. And there's a lot of prevention we can do with those as well. And they typically don't bleed, but they get kind of crusty or keratotic, as we say. And so that's kind of a good example, this raised thick spot, like on this person's, like the back of their hand. So the hands, the face, the chest, those areas. So just kind of in summary with that, so skin cancer, these are really common, and they're all fairly preventable. The sunshine, genetics, decreased ozone layers, who knows? They'll find more and more, but skin exams and catching them early, they're really fairly easy to treat. So we'll kind of run through some of that as well here in these next few slides. So, all right, other effects, these are kind of benign effects. So if you'll look like at your arm or your neighbor's arm or your spouse, you can look at the underside of your arm to just the top side of your arm, and you can see cumulative sun, and you'll see like the underside is lighter versus the top side. The top side is a little bit more tan. So sun damage causes like those pigment producing cells to kick out more pigment. And so it's darker. You can also get, over time, more wrinkles, and you get some easy bruising and these brown sunspots. And then of course, potentially skin cancer. These are called solar lentigos, or sunspots, that pretty much everybody asks me about every day. We reassure you on those. This is freckling that we'll see in younger people. This is easy bruising on the arms, which is through age and sun damage. It's not a sign of anything bad. It just happens. You lose a little bit of the cushion that you had, when you were younger, but really common on the arms and the lower legs. This is bruising as well. Again, super common. They really haven't invented anything great to kind of fix that. Certainly you can buy a lot of things off of Amazon, but they really haven't invented anything great for that. So, effects of UV exposure. Scientists believe sunburns can alter the immune system for even up to a day, and it kind of causes some mutations in the way the skin cells are produced, and that can happen whether you're lighter in skin or darker in skin, and it can take a while for that to really take effect. So sun damage, even as a young adult, sometimes it takes a while for that to turn into skin cancer, sometimes even a decade or two down the line or longer. All right, so we'll run through just some guidelines for protection, and most of this you guys may know, but I'll kind of run through that. So eye protection, sunglasses. Now there are sunglasses that really just look cool, but don't block out any of the UV. So you want to make sure that they've got something on there that says UV protection with that, something that maybe even wraps around there if you're going to be out at the beach. Or outside, something like that is kind of important if you're actually wanting to protect yourself. All right, tanning protection. All right, sunscreen is important. There's some misnomers out there. So normally a 15 to 30 SPF, that's the sun protection factor, is plenty. An SPF of 15 blocks about 93%, and that's what the Academy of Dermatology recommends. 30 blocks out about 96%, and really everything above that doesn't help you that much more. It's not wrong to get more than that, but it's a little bit of a misnomer. You know, for instance, an SPF of 60 is not twice as good as a 30 on that. So it's almost, I guess the sunscreen company may argue with me, but it's a little bit of false advertising on that. And as we mentioned before, you know, try to apply the sunscreen maybe 15-20 minutes before you go in. You don't need a whole lot on there, but a light film would be plenty. And then if you're swimming, make sure you're reapplying it. Waterproof is false advertising. There's no such thing with that. Now you can be allergic to some sunscreens, so there are options for ones if you have allergies to some of the products within it. It's typically one of the additives within that. So there are options with that, and your dermatologist can go through options with those products if you find that you're allergic to sunscreen. All right, so here's a hat. I'm the first one to tell you that it would be, if I was trying to talk to my son at that age to wear that hat, he would give me a hard time on wearing that hat, but that is a good one. You know, if you're working outside in the yard, that's great for the back of the neck. And that kind of shirt is great. I mean, in the fact that it breathes really well. So they do have this sun protection fabric that you can buy. I'm not a big fan of like buying a whole bunch of those because they can be a little pricey, but I do like the fact that they breathe really well. But as far as paying a lot of money for those, I'm not sure how well they help you, because you know, if you think about it, when was the last time that you really got burned under your clothing? But I am a fan of the ones that breathe, just so that you don't overheat with that. So cotton and polyester are good. The one thing that I really didn't know when I did this, you would think the light colors would be better, but apparently dark colors are better at absorbing UV light. They're not better at making you cooler, but you know, dark blue, that kind of color would be better at absorbing UV light. And appropriately designed clothing is great for protecting you from the sun, of course, you know. All right, so kind of winding up here. So the melanoma guidelines. So this is for you. I don't know if any of you that have had skin cancer or melanoma. So so typically, if we have a patient with melanoma, when we bring them back in. So if I take a biopsy and I have melanoma for a patient and we have it removed, I typically bring those patients back in about 6 weeks to kind of go through what we need to do going forward. And a lot of this depends on the depth of the melanoma. And there's national melanoma guidelines on how often we need to see those patients. So melanoma is not really a death sentence for probably 95% or more with that. So the office skin exams are really based on the depth of the melanoma, and your dermatologist really will go through that with you. And interestingly, like most of our melanomas that we find are what they call in situ, which is just in the really top layer of the skin. And what we're looking for, if the depth is a millimeter, not an inch, but a millimeter or less, you know, we can see you. Actually, the guidelines say you can be seen once a year. We take it a step above that and see you every 6 months with that. If it's more than that, depending on the depth and what was involved, we will send you out to an oncologist where, based on that, there's laboratory screenings, CT scans and PET scans that they will do based on those guidelines. But we will have the oncologist follow with you, or follow with that particular patient with that. There are also some new guideline or new optional tests that can look at the genetic expression. So for a really thin melanoma, like the survival rate may be 95% for 5 years down the line. And they're saying, well, who is that 5%? So there's some additional tests where they can do some genetic expression tests to say, hey, do we need to bump this patient up to do additional testing on that? And so your dermatologist can talk to you about that, or I'm happy to talk to you about that. The other is self-exams. So we kind of run through that, like what you need to be looking for, so the easy one, if you've got a new or changing mole, then we like to, our patients have the backdoor pass. They can always call us and we bring them in early. If it's a dark mole, and some melanomas actually can be a different color. They can be red or bleeding, so we kind of run through that with them. There's certain vitamins you can take, like vitamin B, as in boy, B3, that seems to help with things. And there's also a little bit of a relationship with melanoma and certain other cancers, like, for instance, breast cancer and pancreatic cancer in certain instances, that we like to make sure that our patients at least have a primary care physician or an OB, so that they're, not that there needs to be extra work done, but, when it's time for a mammogram, that, they're getting their mammogram done. When it's time for a colonoscopy, that they're getting their colonoscopy done. So, I'm going to go to the next. So the other cancers, so non-melanoma, and these are what we were talking about before. So basal cell carcinomas or squamous cell carcinomas, and these are really, really common. I mean, so we'll find many of these like every week. So traditionally, for most people, and I'm going to put this in perspective, I will have a basal cell and probably a squamous cell skin cancer in my life, if not more. So usually those patients, like, if I have one today that's a squamous cell, we'll see them every 6 months for at least 3 years. And then if they're clear, we'll back them out to once a year. If somebody's had recurrent ones, then we'll see them 6 months or even a little bit more than that, forever. And then we also teach them self-exams as well. And then there's also some importance with that we can, important options that we can do from prevention standpoints. Like there's some creams that we can do to kind of get rid of early ones that they can't see. And also the B3 vitamin we talked about earlier, that's a great option to kind of turn down the skin cell turnover that may help them in the future with that. So. All right, and this is the last slide, I believe, connect with Georgia Core. I will, before we go to questions, I will say, because I have a lot of patients coming in, I am definitely not anti-sun. And so we have patients come in and they're, they get their skin cancer and they're like, I'm never going outside again, or I'm not going to do this and that. So I think you need some sun, a little bit for vitamin D. I think you need it for your brain and for your mood. And there are instances, believe it or not, where we'll recommend sunshine, for certain conditions. So like a little bit of eczema, a little bit of psoriasis with moderation is a great thing. So don't completely shun the sun, I guess I should say. With that, but thank you.
Thank you, Chris. And we do have a couple questions. And before I unmute one of our attendees to ask her questions, I thought I'd go ahead and ask one that kind of leads off from your last couple slides. And that is, of those cancers that you kind of went through, which ones are found more commonly in people of color?
Oh, that's a great question. So probably this, I don't know statistically wise exactly nationally, but at least in our practice, I would definitely say squamous cell carcinoma by a hair. Probably we see more on the shins, and so squamous cell carcinoma, you can get it's kind of hard to say whether that would be from sun, but you can get squamous cell carcinoma from injuries. So for instance, from like burn wounds, we will see it come up in that area, and they're not really sure the exact reason, or at least I'm not, so there's a thought process of maybe if somebody had somebody's, their legs too close to a heater, or maybe they got burned at some point, you can get it in those locations. So maybe that reason, or maybe not. Good question though.
Thank you. It wasn't mine. Someone else submitted.
Oh yeah. Okay. Yeah.
So, but thank you.
Yeah.
And then I'm actually I will go ahead and unmute. Cindy has a couple questions, so I figured I would let her ask her questions. I'm not sure which one she finds most important. So.
Yeah. Hey, Cindy.
Can you hear me?
Cindy,
Yeah,
yep,
I can. Yeah.
I can hear you.
Oh, good. 'Cause I'm trying out a tablet at home and I'm hoping that it works. So that's good. So, so when do you think it's best to start getting skin exams? Like what age?
Well, I said I could hear you. I may have had you jumbled right there.
Yep.
I'm sorry. Hold on. I don't know. Is that any better?
No, I think, but I'll take a stab at it. I think you're probably trying to ask, one of your questions online was, what if the melanoma is diagnosed at a young age?
What if melanoma is diagnosed at a young age?
Yes. Yep.
Like, where do you go from there? Like, as far as follow-up?
That I don't know.
Is that what you're asking? Oh, I'm sorry. Was that the question?
That was her question. Yeah.
Oh, yeah. Well, I mean, you continue to get followed up for life with that. So, and it depends on the depth of the melanoma. So if it was a really thin melanoma, typically every 3 to 6 months for the first 2 to 3 years, depending on your dermatologist. And we have plenty of people that have melanoma 20, 25 years ago that have moved to the area and haven't had anything since. And we actually just see them once a year at that point. But you need kind of a lot of our education revolves around making sure they understand they need like a full head to toe exam each time they come in. So.
And then Cindy, please feel free to, I've allowed you to unmute. So if you want to try again, please feel free. But next question, and can you hear me okay, Chris?
Yeah.
Okay, good, great. Is she asked, are skin cancers from squamous cell associated with HPV?
Oh, that's a great question. So it can be. Yeah, absolutely. So there are a few of those that untreated that can mute over to squamous cell carcinoma. The more commonly, the ones you think about associated with the ones that are associated with STDs, and there's 150 strains on that, but it's possible. And so it's not the kind of thing that takes place instantly, but every once in a while we'll find somebody that almost didn't realize, and they'll come in 10 years down the line and they'll have one that's turned over into a squamous cell carcinoma that we biopsy. Good question though.
Well, she has a couple, so.
Yeah.
And then two, well, maybe not related ones, but how often do you see melanoma in the eye, and are there special circumstances that you see this in?
So we never see it in the eye because we don't have the capabilities to look back at the retina. It's almost like, oh, by the way, my ophthalmologist, I have a history of melanoma in the eye. So probably that's something we should do a better job making sure that we're asking somebody if they're getting eye exams. We just kind of assume that they are with that. So, but it's always, honestly, in the length of time I've been here, I've probably had maybe 3 people that have told me they have a history of melanoma in the eye. I've never seen anybody that's lost their eye, quite honestly, from that. It's just, oh, by the way, I had melanoma in my eye. So.
Thank you. And then she also asked, can you get melanoma on skin that does not get exposed to the sun, like the underside of your arm that you mentioned?
Absolutely. So on the, it's almost more common there than in other locations. So the bottom of the feet, you can get it there. We look in between the toes. I've had a gentleman that was 86, had it in the genitalia region. And so it's one of those things that, although we think sun has something to do with it, you just may get a couple rogue cells that just don't behave and just kind of go haywire. So for sure.
Thank you. And then, so I guess to kind of round everything up, when should people start getting skin exams?
I think in my book, I think at least by age 21, that's kind of subject to debate on that. Definitely if there's a family history by age 21, it's good to get a good baseline, just to get a good once over with moles. And the other thing is if before that, we kind of rely on parents or pediatricians to say, when they're getting their exams, to say, hey, you've got a lot of moles, you ought to come in and get checked early beyond that. But, once a year beyond that, just to get a good, just to look at you from head to toe, just to say, hey, we need to watch you. And every once in a while, we'll see somebody and say, hey, we can look at you every 2 or 3 years, but at least by age 21.
Great. Well, thank you so much for your time. Thank you everyone for your questions. Really appreciate it, especially on this 95-degree and sunny day here in Atlanta, and I'm sure much warmer in Savannah right now. So it's a very current need. So thank you, Chris. For those who joined us today or were not able to join us, we will be posting this on our website and on our YouTube channel. So feel free to watch the recording there. And we also post reminders on our social media channels. So please connect with us at georgiacancerinfo.org, or feel free to email us at info@georgiacorps.org. Again, Chris, thank you so much. We appreciate it and hope you have a wonderful weekend. Safe week.
Guys, thank you very much. Have a good day.
Thank you.